AI being everywhere, affecting everyone in every day, every walk of life, right? How is it going to be disruptive in healthcare is what the question that we are going to look at. And we are going to specifically look at the opportunities that India offers, right? So we are talking about several technologies coming up in AI, and India could be an emerging market for that, right? So we are going to talk about the opportunities and followed by challenges. And then we also will have a closing session on how do we move forward, right? So with that, right, I start with an initial question to our clinicians who are here, right, to Dr. Jagannath. So, so we are talking about understanding the healthcare landscape of India. And we know that the supply demand problem is there. And also there's a big gap in the urban rural gap, right? In the in the context of healthcare sector. So how can AI can fill this gap, right? So that's the question that we were looking at in terms of, so we understand these problems in the Indian healthcare setting, how this technology can be a gap filler there.
So thanks for the invite to this wonderful campus and very bright students here. I think morning you have set the tone as far as the gap is concerned. I can only talk about cancer. If you really look at cancer scenario, in this country, in India, you have one oncologist for 1 million population. Compare it with US, 161 oncologists for 1 million people. So the gap is undoubtedly great. But that gap also is that also gives you a kind of an opportunity. Because of the scarcity of healthcare resources, both in manpower as well as, that means physical as well as the workers, you need to have technological solutions. If I can just take 1 minute, Vinod, I've talked to you about it. The reason why I'm showing you to all you youngsters who are likely to maybe get into some startups is we have worked on this first cancer care as part of the World Economic Forum project, mapped out the gaps, critical gaps, mapped out the potential solutions. So the fourth industrial revolution of World Economic Forum, which are emerging technologies, offers solutions. Now, the most important thing what we have to understand is we must have the feet on the ground. The data can be in the cloud, but we need a system where there are people on the ground who are looking after the patients and the population. At the same time, we can have analytics on the and the data on the top. So that is how we should build up one problem at a time, one solution at a time, and not trying to feel that AI is all be all and end all for all the problems and all the solutions.
So I want the opinion of others in the panel.
In fact, thanks, Doctor, for really setting that up. Doctor spoke about oncology. Let me talk about cardiology. And this is something that we actually did in a setting in Manipal. What we did was we said, let's go to a rural clinic and sample about 680 people who come there. And for with known problems of hypertension or diabetes or elevated lipid profiles or whatever. And then you realized saying that out of them, about 40% of them had some sort of a cardiac intervention that was needed. 40% in a population of 680 is just too much. Now, so what we did was we said, let's do an ECG. But the challenge that you have was to read an ECG in its fullest form, you need a MD cardiology to do that. The question that comes up is in a rural setting or in a semi-urban setting, where will you have an MD for that? So, okay, so what is the next step? You take the algorithm, you take the ECG, push it up into the cloud where you have an algorithm that looks at possible deviations, compare it with normal and non-normal, and do that screening, and then give the feedback to the primary care physician in terms of what the results are. Once the normal and non-normal is done, at least the first level of screening is done, then you take the non-normal ECG and do a next level of analysis to see whether it requires an MD intervention or does it require an immediate attention to a hospital or can you sort of do a series of tests that is next needed? So you basically take that non-normal stuff and segregate it into 3 parts. Now imagine, and then the process goes on. Now imagine the case where a patient walks in with a myocardial infarction, which is basically a impending heart attack, and you're not able to attend to him. We were 2 cases in that survey where we had to do a stenting right away. We had to take him to the hospital and get it done. Now, that's only a sample 680 population that I'm talking about, and look at 1.3 billion that we have. It is impossible for us to have doctors dispensing the same care what our senior doctors and consultants who do it in the tier 3, tier 4 cities, in the tier 3, tier 4 hospitals do it. It is simply impossible to do that, to make that happen. So that's where the role of AI comes in. What I'm giving you is one example. We can talk through several such examples, but then suffice to say that AI can help the doctors, help the patients in the first level of diagnosis, but then that's not a be all or end all of anything. We still have a long way to go there.
Thank you. Dr. Rajesh, you're there?
Yeah, I turn on video also. I completely agree. I mean, there is a impending gap, a very significant gap in terms of care providers as well as, support staff, not just the MDs, not just the oncologists, and no offense, not just the cardiologists, but broadly, there is a very significant gap in terms of healthcare providers in India. And for that reason, and also for the variation that we see in terms of their training and education, we need to have solutions which will bridge that gap. We know that there are folks who have immense experience, having trained across the world, as well as having serviced very large populations. The footfall we see in our hospitals is very different. So there are professionals who are, as clinical professionals, the best in the world. But at the same time, we have those who have, not the same level of experience. So from a care quality perspective, standardization of care perspective, we need technology solutions. We need certain solutions. Obviously, it'll take years to build up the training infrastructure, and we know that is happening with the additional AIMS hospitals that are coming up, and a lot of investment that we are seeing. A steady increase in the percentage GDP investment that is happening. But if we need to leapfrog in this space, if we need to, care for the very, very productive populations that we have, we need solutions, and that's where AI or any solution of that form, whether it's point of care, whether it's telehealth, in different forms, is needed to meet that need. Having said that, cardiology and oncology are certainly very big pieces. We see them; they are very large, needs in the nation. But at the same time, there are very large number of deaths which happen due to infectious diseases. TB, as everybody would know, is killing more people every day than perhaps, I don't have the exact numbers here, but then many others. So there are diseases which are more prevalent and could have a more quantitative benefit in terms of life extension, in terms of quality of life that can also gain. And monitoring that and being able to diagnose it, as well as provide the support structure through AI methods or others, just to ensure there is compliance on their prescription, and just digitizing that whole space and being able to give notification alerts and so forth has also tremendous benefit that can come in. So it's basic and digital infrastructure that can come in, as well as advanced smarts that can come in.
Okay, that's an excellent way to articulate the point.
Vinod, if I may say that
please.
you had also mentioned about the urban-rural divide.
Yeah.
It is absolutely stark in this country that everything, cancer, cardiac, all concentrated only on the cities. 100 kilometers from here, it'll be steep drop in care. There are 200 kilometers, 300 kilometers, they might not have even seen a doctor in their lifetime. This is a reality. Now, Rakesh has touched upon a very important thing. By the time you develop a physical infrastructure, aims and medical students, just forget about it. As a doctor, I'm telling you, you don't need doctors to prevent cancer. You don't need doctors to detect cancer. It's a very radical statement. What you need is a very well-trained nurses, primary physicians, and the field workers who can detect cancer. And that is then they can detect diabetes, they can detect hypertension. So we need to kind of really skill this population and shift the skills. The skill shifting is the most critical thing to ensure that you have an expanded workforce easily reaching the rural population.
Yeah. So, Aris, could give us some examples on, say, currently what are the things which are happening in this space, at least in the rural setting? I mean,
Yeah, thanks, Vinod, for inviting me. So I think catching on with what Dr. Jagannath talked about, right, in terms of the urban-rural divide, one example that I can give is a simple use of non-invasive imaging technology to know anemic level, right? That would have massive impact on women and children health in rural part of the country. As you know, as per the last reading from the WHO, 25% of the world population, specifically in the underdeveloped and developing countries, and primarily in rural setting, are affected by anemia. So using smartphone cameras, AI applications are being developed for imaging the conjunctiva and fingernails, for example, to detect anemic state. These are simple things, but cost effective at the same time, right? Simple makes it easier to deploy in a healthcare setting which is in the rural, right, where the skill levels are low, and cost effective because we have a rural population who can not afford this in terms of higher screening or diagnostic cost. I think if these kind of technologies can be put to use where we make it simple and cost effective, then I think there'll be a lot of change, and probably we can bridge the gap that we currently see. I think the detection part of the disease early in the disease cycle is the most critical one, right? If it's an anemic or it's cancer or any of the heart conditions, as Ravi mentioned. So I think all of these the cruxes, if we can detect them early, I think we need to. There's a lot more research needs to be done to know what are the earliest markers that we can rely on decades into before you get into the full-blown disease state, right? I think AI can help here as well in analyzing complex data in order to come up with meaningful markers that are screenable, cost effective, simple to use, right? It's a long way to go. I think that's a kind of challenge that we are up against, right? And I think we need to look at this as an opportunity.
Yeah. So that's talking about the prevention versus the diagnosis part, which seems to be the primary things that we are touching upon here, right? So given this disparity in our healthcare setting, can that be also our strength in moving forward in terms of developing AI technologies for the world, right? Is there any indicators for that? Dr. Devdutt, you want to add on to that?
Yeah, I mean, so definitely one great thing in India, at least like during our experiences with COVID, was that you're sitting on tons of data. So when whatever people would take as the biggest of the demographic challenges, people like us who really deep dive into data, we really love when in one small time. So it's basically a very small zone of time in which you can get down data, which otherwise, in case of any other disease, would have taken you about 2 to 3 decades in order to collect it. That's definitely there. The challenge which comes in over here is that we don't have standards for annotating all the data and preserving all the data. So there is this whole chaos. It's very unstructured. And what we need to do today is that, see, for breast, there has been this.
I think there's some issue with your mic or some interference is there.
Just a minute. Let me just switch the source to something else. So am I good now?
Yeah. Please go on. Yeah.
Okay. So the primary thing which we need to look as of now is that we need to have standards around how we really collect the data. So in a sense, like reporting standards need to be made common and they should be adhered and followed. And we have BI-RADs for doing it for breast, you have for lung RADs, you have Thai RADs, all of these coming up. But eventually, I think we need to realize that there has to be this very simple thing on like what will be the minimum essential data which will be collected when the patient comes in order to just sign up for a visit, and they should be made common across all hospitals everywhere. The next thing is like, and these should be as standard advisory. So all medical associations or regulatory councils and everybody can really come up with these standard denominators over there and say like this is an advisory. Nobody is forcing you, but then at least if we have an advisory, it really makes it nice. Today, when somebody wants to start a study in order to even collect the data, one of the major things which we face is that first is we don't know exactly what is to be collected, how to annotate, how to preserve everything, because data is as good as how great it is to retrieve from an archive. So today what we have is a data dump. We are nowhere even thinking about building a data lake. We will not be able to do a data lake because that data lake would essentially become a very big dumping ground for data. That's what today's PAC systems, today's hospital IT systems, everything is. So what we are telling is essentially a dump yard of data. We really need to know how to categorize, sort it out, put it down in supermarket like shelves so that we can make real meaningful use out of it. So this is a point where we need to really focus on at this time.
Thank you. So this brings me to the next question, because you touched upon the data aspect of it, right? So given this opportunity, and then we see potential to develop several AI applications here. So, but then looking at the data that is available in various hospitals and any other centers, diagnostic centers, right? How do we make sure that these data are made available to, say, a community which is sitting somewhere else, right? So how can we bridge this gap also? So we talked about urban rural gap, right? But there's also gap in how a technologist would work with a clinician, right? So how do we minimize that gap so that these things are accelerated, right? So I leave this to the panel, any one of them to comment about it.
In fact, data was one of the big gaps which we found in our brainstorming sessions. Now, this is a set forward path which we see as far as cancer is concerned. There is what's called the Cancer National Registry, which is a minimum set of data points. So that is your minimum. So that is something which has to go with every single patient who is diagnosed with cancer. The second thing which is important is interoperability and exchangeability in secure fashion. This also is established what's called the FHIR standard, FHIR standards, which are there to exchange data from, say, one hospital. I now see a GP, then I walk into a tertiary care center. Through a FHIR standards, all the fields can be matched. So these are existing standards. Now the big question is therefore, how do we ensure that the standards are followed? That is the fundamental question. And who are the culprits? The culprits are the hospitals are the culprits. Where they don't want to follow any kind of a thing. I can always say that I'm a very busy doctor, I'm saving lives. I know I'll run around and show you that I'm very busy. But I don't have time for data. And today morning, it was said that data is for the future. I have no time for future. I have time only to go and have my lunch. So I'm not going to fill up. So it has to be made something which is very simple, possibly using NLP or natural language processing. I dictate, the data sets are filled up, and then I move on. So if this is developed, and which is what we are trying to develop, then you will have a filled in data format, which can be exchanged across the different hospitals. And also the data has to be collected like the case file at different points in different digital formats. So it has to be a real-time, online, one-time data collection, which is planned in our project. So that is going to be the future. And this has to be done for all the diseases. So, and these minimum data sets are actually available. They're actually available by multiple international agencies, so which we need to just adopt and ensure that they're followed.
Thank you.
Availability of quality data is always a challenge. I was talking to Dr. Vinod saying that I was taken to a government agency when I asked for primary care data, and they gave me 20 million records of paper sheet saying the couple of halls full with paper. Now you go and take whatever data that you want. Now that is not something that is of any use to anybody. I can have a random number generator which will generate all the data for me maybe in 2 hours. So the question that comes up is when we say data, how do we qualify data? And what Dr. Jawahar, what he said was exactly right in the sense that is there a data in a longitudinal manner saying a patient comes in with X, shall I say, diagnosis, we did Y intervention, left a period to elapse. At time point T3, we took another shot of it, saw what the parameters were, and so on. So basically what you're trying to do is to build a complete case file and history saying what intervention I did, what was the disease profile, what intervention, and what was the outcomes. If we have this for a substantially large population, then you are able to build a cohort and a certain amount of intelligence into the algorithm, which tells saying in which part of the cohort does your patient fall and what the outcome could be if you were to pursue this line of treatment. I think to me, we are quite far away from it. Then the way that data has to be structured and annotated and preserved, we got to know of it, I would say maybe about 10, 15 years back. I think we are still trying to build our own data sets, and I'm sure we will get there because people now understand what it takes and what is the value of trying to build such a thing. So yeah, I think there is a certain amount of awareness that is now created.
See, the COVID was, of course, the most disturbing thing, but it also kind of disrupted the healthcare in a big way because telehealth and diagnosis was accepted without a question. 75% of my consults are on telehealth. So there is, patients have actually accepted, I don't have to feel the doctor and hold his hand. So that is one good thing which has happened. Some people still want to come and hold, that's a different thing. So second thing is, or I want to hold their hands also, it's a different thing. So that's fun. The second thing which has happened is that all of us registered in that COVID app, whether we liked it or not, painful or not. So the government has, they have close to 500 million ABA or in the unique numbers. The NCTPS system developed by Dell and Tata Trust has 200 million records. So this is still there. Now the only thing which we need to do is, as you rightly said, the patient journey has to be completed in the hospital, outside the hospital, and the follow-up. If this loop is completed, then you'll have a cohort, a longitudinal cohort of patients, and that is a gold mine.
Absolutely, no questions about it. And you know what, doctor, and you might, I stand to correction on this one. Very often we find that we use the algorithms that are developed for the Western world, although the body characteristics are very different. So if we were to develop something for the Indian population, I think the applicability and the inferencing capability for those set of diseases that we have in India could be a lot better.
No, there is no doubt about it. In fact, I was just telling Vinod also that Google has stormed saying that they have developed a dermatological cancer detection. And they said this is the game changer. And that by next year, it was found to be a flop because they tested only in Caucasian population and never tested the colors.
Yeah.
So the entire thing, so you are very right. Diversity of the population is very critical. So diversity of data is what is important to make sure that the algorithm is a kind of functioning across. I also want to ask a very stupid question. Why do we call it an artificial intelligence? There's nothing artificial about intelligence. I would call it something else, maybe assisted intelligence or something else. Because the reason why I'm saying is the moment we said artificial intelligence, and then you know the famous story of IBM Watson, billion-dollar development, and found to be in Memorial Sloan Kettering, MD Anderson, big cancer institute, to test or to compete with an expert. And within 5 years' time, they threw the machine out and the project out. That is a problem, that artificial intelligence cannot be taken as a competitor for an expert, which is different thing completely. So you need to have an assisted intelligence. I feel it's better.
In Philips, we call it adaptive intelligence.
Oh, that's also better. Anything other than artificial is better, I feel. I don't know. Some of you should come out with one thing which is not artificial, and that should stick. Yeah.
Yeah.
That's excellent point. Right. So,
Just a
Dr.
brief
Devdutt,
comment on that. I think the companies certainly have the muscle power to do that. I think when we got into our initiatives, we refer to it as applied intelligence, right? So one can call it whatever, we know what really it is. On the data topic, actually, I want to ask Dr. Jagannathan, can we really collect significant or sufficient amount of data, which would, even if we limit it to the Indian population, which has enough diversity as it is, let alone the white Caucasian and the African American and the African population, whatever, or Southeast Asian population, do we have enough instances to cover the disease diversity? Because from what I understand, differential diagnosis in oncology is a very important challenge, right? The tumor typing itself. So if I am looking for 1,000 subjects of a certain, demography, of a certain ethnicity, of a certain tumor type, of a certain age, of a certain gender, by the time I come down, we will never have sufficient data, or there are limits to where we can get to, even if we could collect ideally all this data digitally, right? What I'm throwing out to the student population here, we have to look at other mechanisms. Yes, we are moving towards data-driven sciences, and even AI is moving away from generating new artificial intelligence networks to data-driven AI. At that point, we need to focus on data. Yes, I think we will all agree there, but we have to look at alternate mechanisms, which points me to understanding deeply the domain, understanding the biology, the physics, the chemistry, to be able to simulate some of this also, because it's going to be very, very difficult and to offer competitively, right? We have so many startups, others who are all looking for the same set of data, but if we take the same small pool of data and generate models, there's not going to be repeatability or reliability of those models.
See, Rakesh, I agree with you or disagree also with you. Agree with you in one sense as far as the students are concerned. Disagree with you because see, we are going to start the pilot in Meghalaya next month possibly. There are only 5 cancers. There is oral cavity, there is cervix, there is breast, there is lung, and there is esophagus. They have high incidence. One population, the East Khasi Hills, very homogeneous racial population. And the entire district will be screened. So in 1 year, you will have a data about the entire district, 5 cancers, all data is there. Why is the data there? Because every single, the government has committed to screen every single person, number one. Number two, you don't get paid for diagnosis or treating unless the data is complete. The one thing which drives all of us, in fact, whether we like it or not, is money. Healthcare needs money. If you want the money, you have to put in the data. UPI, you have to do the Google Pay, Jolly will put in your data. As simple as that. This is the fundamental thing which will drive the disruption or the data collection. So we are hoping that with this kind of a thing, and which is going to be there in the future, insurance sector is in this one, is the what is going to give the data. Risk profiling is a very important, which AI can be AI driven, so that we are not screening the entire population. We are only screening the high risk population, which is very, very important tool for us to see. So these are the 2 things which are going to be the differentiator. And one of the sources I wanted to keep it open to this one huge source of information is insurance data, because insurance captures the journey right from the time of insure, the comorbid conditions, and possibly the death. So if someone can actually look at it, it will be a wealth of data for risk profiling.
Absolutely. Cannot agree more.
I agree with you. I'll take a moment here to respond to Dr. Jagannath. I don't want to belittle all the data collection efforts that are there. I think that is very, very important. My point really was that, yes, at a screening level, if you're looking at screening versus diagnosis versus therapy, at the screening level, yes, having the high level indicators of prevalence of cancer, incidence of cancer, and the 5 major types as you're doing in Mizoram would be, tremendous resource. And we need all of that. But if we go slightly beyond that, when I have to plan for therapy, I have to do, and you would know the terminology, what treatment to do. Then the cancer typing becomes very important. At that point, we need genetic data. We need other detailed data for which, even if we collect all of the data, it may not be sufficient to build the right models. That was my point. We still need the domain expertise. We need all additional multimodality data to be able to make proper care provision across the care pathway. At the diagnostic and screening level, yes, absolutely, these efforts are paramount.
No, I think we know. I think you should talk about the project. Oral cancer is the commonest cancer. Risk profile: tobacco usage. Diagnosis by simple visual image or a smartphone image on a AI-based this thing. What's the difference? And I have seen in the last 4 decades, we are continue to see the same stage 3s and stage 4s, continue to see advanced cancers, no treatment. If I move it to early stage, 90% cure rate with a literally 10 to 20% of effort. So I don't have to spend money on immunotherapy or advanced therapies. I have to spend money on prevention and early detection. Yeah. If I move the needle to the
Good
left
point.
and detect them in stage 1 and stage 2, nothing needs to be done except simple, straightforward, available treatment. So that should be a most cost-effective this thing. And I think we will, I hope to collaborate with IIIT and develop this simple smartphone-based imaging at the periphery to detect oral cancer. That's it. The reason I'm saying is that a pre-cancer to develop cancer takes 10 years. So if I can intervene when it is a pre-cancer and the patient, or sorry, not even patient, the subject stops tobacco usage, the pre-cancer is reversible. That is the power of detecting an early pre-cancer. And that is the power of AI in the future.
Thank you. Dr. Devdutt, he has been raising hands for some time. So
yeah, I think like most of the topics I wanted to cover got covered. There's one point which I do feel. So the source, we were on this point, like, why would people give the data? How would you collect it and keep it down? It was very rightly pointed out that insurance risk is one of these biggest motives why you would need the data and where you can monetize out on the data. And I think going down with the trend in all of these health insurances today, that they do pay out for preventive screening. Now, what can be really ensured, even from the insurance side of it, that you don't do a payout until the end beneficiary, the customer over there, actually profiles in all the data. Once you start doing that, because we need to see that where is the whole economics closing, and over here the only industry which is going to make the massive first amount of money is essentially the insurance industry over here. So they are possibly going to be the guys who are going to give you the first record of all the data, and on the next subsequent ones, I mean, today I know that even if you do an imaging test, the insurance really wants you to upload your imaging data over there. You need to upload your DICOM files and everything, otherwise they're not going to pay out the bills over there. So the data is coming to them. Now the next comes down is that, can we put that into a regulatory framework? Can we put that into a framework which can be now made shareable? So that's the next problem we have to solve. But the compliance part, now we are really going deeper and deeper into that.
okay, and any more points on that? I mean, so I would like to add to.
I have a couple of points to add here on the
Yeah.
data. Right. So I think one thing that we all have to realize, and I think Dr. Jagannath touched upon it, pandemic, I think that has really changed the mindset. Pre-pandemic, people were not ready to share data, right, for research. I think that needle moving action has happened. During the pandemic, people used HRCT, lung HRCT, and they sent it to the cloud to infer a lot of things which were sort of no before pandemic. Got acceptable, right? Use of cloud technology for inference, people sharing data to external to their hospital to infer. I think all of this is a good thing, right? Another thing that I wanted to talk about data is, digital twin, building a model of the human system. I think somebody alluded to the chemistry, biology, and physics of the human body. During the pandemic, there was a German company which built the model of the lung that was tunable to the geographical location. So thereby you can adapt the ventilator support so that optimal use of the ventilator for inpatient care, right? And that improved reduced the mortality and improved the patient, getting cured. So I think we need to also not only look for data that you can collect, but also look to build models that can emulate and simulate the scenario, right? So you have multiple sources of data. Then on the one of the things that that is striking in this in terms of AI solutions, when you start analyzing these data, In the case of rural setting, all you need is early detection mechanism. And I think Dr. Jagannath alluded to the oral cancer screening, breast cancer screening can be another one using infrared imaging and so on, right? But when it comes to urban setting in hospital, you can't just throw a AI model, which is a black box, right? For a larger acceptance in a diagnostic community, the model has to be interpretable, right? And I think that's another thing that one needs to keep in mind beyond how you can collect data from multiple sources to gain insight.
Okay, so and just to add to what Dr. Rakesh was saying also, so we tend to want to collect longitudinal data, and so we have to go in the way of cohort being selected for doing it. But then how to generalize them across a population is where the real problem starts. So and therefore we also have to have that framework in mind while we trying to do a population scale screening measures. So
See, as Setu has said, that COVID has taught us that collaborative data can be done and has been done. Genome was available in 2 weeks' time. So the same federated data is what is to be, what we have to do is have a multiple data sources, federate the data, and let people work on it because it's all for public good. So unless if we start doing 50-50 cases in each place, it's never going to reach. So we need to have some 5,000 centers putting up the information. Let people work on it. The federated data is the key.
And I think the India stack that we are talking about is something that will really help us. Because in the India stack, they have actually formatted the way that the data is to be collected so that there is consistency and reliability in collection. So I think that's going to be a big way for us to say, to even from a data collection perspective, as to be how we standardize our nomenclatures and how do we have a consistently understandable data that goes across hospitals, just the federated way that Dr. Jagannath was talking about.
Thank you. And moving on, just to add to more fuel to the discussion. So we talked about data as one thing and say imagining that the data is available. So what are the other challenges or hurdle one has to cross in creating some AI technologies in India, right? So other than the data part of it. So I would like the panel to comment about it also. Anyone from the online to start?
Let the online start.
Yeah, I mentioned already the interpretability of the model, right? I think it cannot be a black box anymore. The specialist would like to understand how the model has inferred so that he develops the confidence, right? But I think I think we also should realize that take some lessons from the outside India context, right? If you look at NHS, they started thinking about using AI in a fashion to automate those laborious tasks of a radiologist or a pathologist. I think these are low-hanging fruits that we should definitely exercise because you instead of attempting at a problem which is classification of lung cancer using ABC modality, multimodal context, I would say if we can automate laborious annotations that the radiologist or the pathologist need to do with their data, right? Which consumes 30 minutes of, close to an hour per patient. If those could be automated and critical insight building and insight reporting is where the time is spent from the specialist, I think the acceptance level within the community, diagnostic community will also increase, right? I think low hanging fruit is one thing. And then of course, interpretability of the model, in my view, are the two biggest challenges besides, getting clean data to build models.
I completely agree with you, Ramat. And the analogy to that is the self-driving vehicle. I mean, it's not that we wake up one morning and we have a self-driving vehicle. We have had so much innovation that has happened in the automotive industry and continues to happen before we can realize the dream of having a self-driving vehicle. When we look at AI in healthcare, we assume that it's all done to eliminate doctors and care providers. I think there is a lot of fat in the system to enhance workflow productivity. And this is where AI is playing a growing role in trying to optimize. And a lot of that is really happening in resource, crunched and also high cost countries. So there are things from NHS and other systems that we can learn as they are bringing their frameworks in. But that really alludes to the bigger point. The biggest challenge in having mass adoption of AI and methods in AI is having a clear business model on it. Monetizing of AI has not been an effective solution. I mean, we've had a lot of venture money that has come in there, a lot of corporate investments that have gone into it. It's not that it has, transformed healthcare immensely, as maybe it's too early, but the business model on that still is somewhat weak. And when we come down to India per se, how we provide these, what you may call smart or intelligent solutions to help, it has to pay for itself at some point. The private healthcare providers, as a lot of it is out of pocket expenditure in India, um, have their own ways of making their mechanisms more efficient. And this is where the challenge is to a lot of the companies which are out there to leverage AI as a mechanisms to sort of make their mega bucks on it. Is a clear articulated business model, and that varies from region to region. Today, it has always been, I mean, I'm sure Google is struggling with it, Facebook is struggling with it. To get revenue out of the system has not been the most trivial. I mean, as you know, if healthcare becomes purely an advertisement delivery system, maybe the money will come. But today, if I have to ask the clinician or the patient to pay a little bit more, ultimately it has to come out of somebody's pocket. And if insurance is doing that, that's great. But that business model clarity is probably the biggest impediment to mass adoption.
In fact,
Yeah, I think what Setu has said are the real low-hanging telepathology. It's about pattern. Pathology is about pattern recognition. So it's very amenable for the slides to be scanned, sent up, an expert pathologist sits there, and then he can interpret the slides. But how do you introduce without the pathologist getting jittery that he's going to be replaced? I mean, that's a fundamental thing. Nobody wants to be replaced. So the thing is that introduce as an education, introduce as a training way by which you can actually train a pathologist in the periphery from an expert pathologist. The same thing with radiology. Expert radiologist trains a radiologist in the field on interpretation of a chest X-ray. And then slowly, as time goes by, there is a transfer of expertise. And the expert is always there to guide the radiologist. None of my radiologists ever go to the hospital, almost. They sit at home, look at the scans from home, and they can interpret. And now the same thing is going to happen to pathology. They have the scanned images in different magnifications, sit at home, have a cup of coffee, interpret hundreds of scans together. Where the AI really comes in is, if you see 100 slides, you just have to pick up 10 slides which are abnormal, which needs to be seen more carefully. And that's where the real repetitive, mundane tasks are the ones AI can really filter and give the pathologists or the radiologists the real problems which they can spend time and interpret. That will be the real benefit.
Yeah, in fact, what you said was absolutely right. We did a sort of a screening application for Qatar Medical Commission, where all that we had to do was to pick up a normal case versus a non-normal case from a chest X-ray to identify whether the patient is having TB or not. Nothing more was needed. So by doing that, we were able to sort of stack out what were the non-normal cases, which was basically about 10%. If I were to look at 2,000 X-rays that got shot in a day, about 10% of them would be non-normal, the balance would be normal. So you stack the non-normal and also tell the radiologist what is your degree of confidence in predicting it is non-normal, if it is 100% or 90% or 70%, whatever. So when the radiologist comes into the office in the morning, he is able to look at all those critical cases first, and then for the normal, he glances over just so that he's able to sign it off. So that helps productivity boost by almost 30% there. And also the radiologist fatigue goes out. That is one part of the story. The second part of the story, which is very, very pertinent, what which Rakesh brought out, was the ability, the financial modeling that AI has to go through. hospitals always looked at IT as an expense. It was never looked at as an infrastructure. If they had X amount of dollars to put in, they would rather go and buy an ultrasound or a cath lab because they know that they can get immediate revenue out of it. IT was basically for the long haul. But I think that tendency is changing now thanks to digitalization. The appreciation of IT has increased significantly. And therefore, if you can sort of face in AI to show the benefits that accrue to people, accrue to doctors, I think that's possibly one way to go. And second thing is moving from a capex to an opex model. Most people look at it as an upfront investment, saying buy this algorithm for $20,000 or $30,000 or whatever. If we could sort of turn it around and saying that you do it on a pay-per-use basis, or productivity link, saying if you see productivity, then I get a share of that productivity. I think that's the way to go, and that's where the world is heading. And that's the reason why people have started talking about marketplace for AI.
Okay.
So as much as you have technical innovation, you also have commercial innovation coming in there.
Okay. And yeah, Dr. Devdutt, go on. Yeah.
Yeah, I mean, we possibly have been speaking about a lot of things which are quick to do, possibly in the next 5 years, 10 years down the line. I wanted to just touch upon one pertinent thing around AI, which we haven't spoken of as of now. And rightfully, a few of the panelists did mention that, I mean, what's there in artificial? I mean, it's just trying to do the same thing. It's recognizing patterns and everything. The point is that artificial intelligence, it gets that form artificial because it's an inorganic form of how intelligence evolves. Now, if that is the form, then let's look into what is the strength of that inorganic form. Let's not try to make it a clone of the organic form of intelligence. Now, once we do that, a very important thing we will now have to really deep dive and think, are we looking at building AI systems which can generate hypotheses and which can validate hypotheses? Well, this is going to be the next thing we would need to be prepared before the next COVID starts. We had COVID. I mean, we'll have COVID Pro, we'll have COVID Pro Max. I don't know, COVID Super Pro Max plus, several of them coming down the line. And before they strike, right at that point, can I still come up with a hypothesis of what should be my care, what should be my interventions, what should be my initial days to enhance the survivability of the patient before I really come down to my medications, vaccinations, everything? And can I now use AI in order to do that? Really, can it go through those millions and trillions of case records, historical records, everything to come up with that? So this can be a very unique thing we can start seeding at this point. It's very similar to what people do in the field of computational drug discovery. I mean, earlier you would have people doing, chemists trying out lots of them to see what are stable molecules and whether they can be manufactured or not. Today, you just have a computer program running. I mean, at the back end, there is just a support vector machine, which is just churning out all of those with molecular dynamics and structures. So can we do the same thing with healthcare data is now the biggest question. And I think we need to really look into that as a strength of AI in the next few decades to come.
Yeah. Thank you. Yeah. So when I asked the panel about the challenges, right? I was also trying to look at what are the regulatory challenges that one has to go through to bring an AI product to a market, right? And now we see a lot of startups have come up, and who's monitoring them, right? For example, in FDA in US, go through a stringent criteria for clearances, right? So do we have any such criteria for looking at, say, a software as a medical device, or have any kind of regulatory norms to scrutinize all of them here? Especially when we see a rush towards building technologies for healthcare, we see a lot more people coming in and building solutions for it. But do we have any regulatory control over them?
Rakesh may be a better person, but I do know that software solutions have also come under the regulatory framework now. So it is there. Now, how strictly are they being monitored, or this one is something which we right now we don't know. Yes, all the hospitals are worried about the data leaks. There's no doubt about it. So the HIPAA compliance, the fire standards are all going to come. Whether that is going to be very important. It comes in the regulatory framework. That much I know. That even it's not the devices alone. The same thing also looks after the software solutions. But Rakesh can correct me if I'm. This is what we found when we started interviewing the startups. Yeah.
Right. I personally am not a regulatory expert, but yes, there is AI policies, countrywide AI policies that are emerging and evolving. Certainly, everybody has been looking up or whatever to the leading effort from the Food and Drug Administration out of US, and they have established not just white papers but things all the way which go into the US Congress for approval of what is software as a medical device, how to manage it, how to also sustain these systems over time. Similar policies are evolving in Europe under the European authority, EU authorities on how to manage it. Besides the data privacy elements, I think we went through a cycle of our data privacy policy, and now we have a refreshed one, which has now been opened up to the public for comments on that. That I just got last week, so it is available. But that is primarily on the data privacy end. In terms of regulatory approvals, much like pharma and the drug controller of India, I do not believe there is a very clear path for getting those kind of approvals within India. I think in most of our commercial operations, and Ravi may have more experience than I have in this space, most of the customers are looking at how it has been approved in other environments, whether it's CE or FDA mark, right? And also CFDA, which comes out of China. So each country has their own, established mechanisms for this regulation. I think we still have some work there, at least for India. But this is purely what I know. I'm sure there are regulatory experts who can add into that mix. And the reason I say that is because, again, there is that digital adoption, and the adoption of AI is just beginning to happen into the mainstream clinical use in India because of all the other resistances that we have seen in the past, right? Both from a cultural context point of view, from a access to labor point of view, from a perspective of how you monetize it. It's beginning to happen. I think that will frame up and get formal.
Yeah, I think from a regulatory framework, there are a couple of aspects that we need to think about. First one is at least all the big companies, they conform to what is called as the CE standards, CE or the 510K standards, or CB or MDSAP or NVISA, depending upon which country you're actually going to sort of sell it out. Even from the hospital perspective, if it is not a CE certified product, then the hospitals are not very interested in looking at it because the efficacy of that is not guaranteed. It has not been thoroughly vetted, which will enable a doctor to base his diagnosis or therapeutics based on that algorithm. I see a lot of startups who come and tell me saying, sir, we have been able to hit 90%, 100% sensitivity and specificity. Now, that is the biggest hoax in all this, because you look at 20 data sets, and if you're building an algorithm with that 20 data sets, then your accuracy is only to that much. When you start scanning it, when you start looking at images outside the data set, the whole thing just falls apart. So sensitivity and specificity is something that we talk in algorithm, which I am myself not sure whether it is relevant or irrelevant there at this point in time. The second thing that comes up is, like, for example, doctor, you talked about pathology. The tissue condition gets impacted based on humidity, based on staining, based on temperature, based on which machine it is scanned. Maybe it is Morphle, maybe it is Philips, maybe it is Hamamatsu. So depending upon the scanner that you have, the images could be different, unlike a radiology, which is a lot more standard. So there also, the complexity of the algorithm also shows up. So what does the doctor depend on? What does the pathology depend on is a question. The third one is, in algorithms, you've got two categories. One is, for a set of condition, it gives you a constant set of result. The second one is, for a set of condition, it starts learning and modifying the code to give you a different set of results. That's more like a learning piece. Now, FDA has allowed you to go and get an algorithm certified by it if it is static. For the dynamic, there is still a question of how that the way forward is going to be. So I think from a regulatory perspective, we are far away from where we actually want to be. Does not have the standards what one would expect, but I think we are getting there given the fact that we are still in a nascent stage at this point in time.
Okay, yeah, that actually, we can get a sense of it in terms of the regulatory process and what has been set up there. And also talking about the challenges, the ethical aspect of it, right? Using AI, integrating AI into healthcare setting, right? Does the AI itself is transparent in the context of what has been used to build that, right? Whether the person who's inventing it or building it is as transparent as they are because it's their product, right? So does all these things also contribute towards the adoption of AI in healthcare settings? I mean,
look at ethics, there are four things that come to my mind. First one is informed consent. For the data that you're collecting from person, are you telling him what the data is actually going to be used for? A lot of people come and tell me, when I ask them for the revenue model, they said, I'll go and sell the data, patient data, which is to me is harakiri. You're not even supposed to do that. It's basically impacting your value systems. The second thing that comes up is the transparency of the algorithm itself. Do we really know? The algorithm is written by a technologist. The implementation is done by a doctor. Tomorrow, if there's a wrong diagnosis, then who's responsible for it?
yeah.
We really don't know. So that's one thing that we need to take care of. The third one is on, shall I say, data security and privacy. Whose responsibility does that fall into? So there are quite a few challenges that we really need to think about before we use data. Now, are we going to say that we will not use data because of these challenges? The answer is no. We will have to sort of find a way out which sort of satisfies all of what we do, plus brings in the benefit that an AI can actually give it to the patients.
I know very well one thing. First thing is my head will be chopped before the computer is dumped into the garbage. So that is very clear. So I have to finally have the answerability and I am responsible for the decisions. That is why I say that assisted intelligence, clinical decision support system, not clinical decision making system. So I have to take the responsibility. I have to stand by the responsibility. And say to this one interesting terminology called the white box as opposed to black box, saying that when I go in the clinics, I have to tell the juniors, why did I make a specific diagnosis? So if the white box says, I have come to this conclusion because of based on A, B, and C is equal to whatever it is, then I know that what is the logic behind the decision making. It's a clinical decision support system. The final handshake has to be from a qualified doctor. And that is the, as far as ethics are concerned. As far as data security is concerned, the final responsibility is again a doctor and not, or the institution, mostly both, and not a system. So this is, on this, I don't think there's any, this is Lakshman Rekha, cannot be crossed.
Yeah, that's
No,
a very.
that's true. But at some point in time, you would also like to know how the decision was actually arrived at.
That's what I call
that's
a
the
white box.
transparency there.
White box.
Yeah.
The white box says that, okay, because you have A, B, and C symptoms, this is not a heart attack, this is only a pneumonia.
Yeah, but
so I should know.
Absolutely. But the question is, how much of the organizations are willing to disclose that sort of that transparency is a question.
Yeah, I mean, transparency, finally, I mean, if I have to take the call, I should know what is the basis of my decision making. So it'll come through, transparency will come through, but I would be happy. This is the difference. A non-expert who's sitting in the periphery would be pretty happy to have a clinical decision support system. An expert doesn't need it because he has years of experience. He has gone through cohorts of tens and thousands of people, but a non-expert to become a reasonable expert will need the support.
Yeah, and as a first level of diagnosis, that's possibly the best thing to do because otherwise he would not have been able to do anything anyway.
Exactly. He'll only say refer to Tata Memorial Hospital, that's all. And all the chaps will come there and
and when it is question of saving lives, it's CDSS is certainly a big help.
Yeah, definitely.
Yeah, that makes it very clear that looking at the expert level of any medical practitioners, right, and then looking at how well the technology can impact the lowly skilled work, right? I mean, that's the win-win situation for AI in healthcare. And any more points to be added?
one quick comment on that.
See,
I think,
Rakesh, payment is never an issue. When we went to Bihar villagers, he said, of course, I'm going to pay for my test. I'll give you equal amount. What you are charging in the city, I'm giving you the same amount. Just take it. Just do an X-ray here, because otherwise I can't go to my farm and do my tilling. That's all they want. Payment is not an issue. They are not an issue. And if you have a lot of money, give it to me. I'll do some better work than that. But payment from a consumer is never an issue. Did you find anybody saying that I want a free ultrasound? No, they will pay for it. This is the paradox which we have. In fact, the poor man pays for it. The rich man with multiple mobiles refuses to pay for it.
I think on that, I have two comments. One on that, yes, from a B2C perspective, it is not a complex thing. Mechanisms have been found out. The challenge is B2B and how to, institutionalize that aspect of it. So if you give AI to people on their phone, I think they will use it. The camera-based solutions, they will use it. They will pay for it. They will pay through ads or whatever. So I don't see a challenge there. It's the B2B where is the challenge, and that's the people who carry multiple cell phones, as you call. One point to the white boxing element to it. One of the major things which is also driving adoption of AI, at least outside of India, has been the number of medical errors. Right there, we know that is something that is recorded at least at some level. It is managed, whether it's through ISO regulations or whatever other mechanisms to capture the quality of delivery. I think that's something that we can also enhance within our infrastructure here to record when there are medical errors, because there's much more knowledge in the error than in normal or correct diagnosis. And if we have, like we are building the cancer registries, like we are building up um, the digital healthcare tracking mechanisms, I think it's as important to also capture medical errors. And if we do, we will know, what our quality is, and that's a good metric to sort of drive, better decision support, if you may.
No, you're right. I think the best way is to prevent medical errors. I mean, that's how checklists and all have come out. The easiest thing to is there are standard guidelines. Stage 1 breast cancer, 48-year-old lady, this is the treatment which is there. Now, as long as the patient journey conforms to this standard guidelines,
Yes.
the payment
NCCN
is done.
guidelines or others, right? Yeah.
That's right. These are all NCCN guidelines. They are nice guidelines. As long as you're conforming to this, there is a payment at the end of the rainbow. If the gold is there, the gold is there. You don't do it and you start doing something different, end of the story, you'll not be paid. So this is the way it can be easily kind of standardized. And I'm honestly saying that most of the doctors want to give standard treatment to the patients. There's no second thought about it. Let me not make you feel that medical profession is completely gone. Now, very, very good doctors are there who want to treat the patients. They have to be empowered with knowledge and skills. That's all what we need to do. And that's what the technology has to enable that, saying that this is the pathway. And if you do this pathway, your patient is going to get better. He'll bring you 10 more patients. So do that the right way.
Yeah. Okay, so any more comments from the online panelist?
I just had one thing on the approval entities, right? I think these days FDA and C are approving about tens of software as a medical device models on a yearly basis. I think it will probably, ramp up. In India, it is CDSCO, which is the approval body. Very early stages, not, we are trying to see how some of the models that we are building will get through CDSCO. But there is a reference with FDA having granted tens of models approval in the past years, right? So it will only ramp up to a higher number. But as I said earlier, better to automate to help assist, as Dr. Jagannath put it, rather than give a complete holistic, diagnostic report out, right? Which I think can come later, much later. But I think what is need of the hour is really interpretability and, automating laborious task, right? Those are the two things where AI should focus on, apart from screening at scale, right? Which is a different problem altogether.
So true, because you basically want to show the doctors that there are some low-hanging fruits that you can go after, and AI as a concept can help them improve their productivity and make their life a lot simpler before we take on the bigger challenges.
Yeah.
That's correct.
Okay, so so we are reaching the end, right? So we have discussed the opportunities and challenges that are there in AI, in integrating AI into the healthcare setting, right? So we would like to have few question and answer session from the audience here, right? So the floor is open, right? Yeah.
My name is Bhakti. I'm a faculty here trying to get some work done in the healthcare space. So I see a lot of the AI-driven technology interventions are driven by clinician interests, clinicians approaching researchers and developing protocols. And then what about people who have ideas from startups or research institutes? When you approach clinicians or hospitals, there are a lot of hurdles in convincing people to troubleshoot maybe whatever system that you've built. How do you overcome those hurdles in finding clinicians who are willing to take up and ride along with you and develop that system? So I see it one way right now when clinicians are interested and they approach AI related researchers. But when there are researchers interested in healthcare and approach clinicians or hospitals, to some extent I've experienced resistance in my little.
Bhakti, you are being very modest. You would have you would have seen tremendous resistance, I would say. Yeah. But I'm also happy that some of the clinicians are actually approaching the researchers. I mean, that's the right mix to do. It's a challenge. It's a big challenge to find clinicians to go with idea. I can identify one person who would be able to help you in some way. So you can collect my email ID or whatever it is, and then at least I can reach out. People can't refuse me, so I can at least say that, hey, look here, you better apply. I mean, tell your two bits about it. But the problems are this thing. But what I would say is that unless the clinician has an interest in a problem, he will not drive it. He will not drive it. So you may have a solution, he would not drive it because you need a clinical involvement. And that's the reason why most of the startups, they may raise the money, as Rakesh said, that they will not move ahead because there's no clinical interest and motivation to take it through. Yeah, you're You're right. Hospitals are very painful. See, they are painful for doctors also. So because they're being run by admin guys who just passed MBBS and they couldn't get into any PG course. That's why they become administrators. So, but that's pain. He knows how he goes and then he doesn't say, no, I don't want an ultrasound machine. So anyhow, what I can at best do is that we are trying to get those people who are fairly senior, who have done their bit, to come out in a pool of experts who will be able to. We have a collaboration with Indian Institute of Science. You have ideas, we'll tell you that okay, this can fly, this won't fly. If it has to fly, this is the pathway to take. That much help, we'll be able to do it. I shouldn't say this because conflict of interest, but we have a pool of doctors in different disciplines. Basically, we are focusing on NCDs, diabetes, hypertension, and good pathologists, medical oncologists. So we're all there. In case you have a problem, feel free to reach out, or I'll put you on to somebody who will be able to respond at least and tell you, go with it, don't go with it. That much we can do.
The other perspective as to why this is happening. Most of the startups, or quite a few of them, they go from a technology perspective, saying that I like this technology, therefore I'm trying to do what I do, and try to force fit or retrofit the solution onto a problem which may or may not exist. So from that perspective, the team here, or generally I would say, would serve yourself a lot better if you go and understand what is the problem, what is the, and even if I were to do a Pareto, if I were to prioritize the problem, what is it that is going to be a top of mind, which keeps the doctors awake at night, and is that something that I'm going to solve? I think that will do a lot of good rather than approaching the solution from a technology perspective, which when it hits the clinical barrier, it will fail. And that's where I've seen most people doing it.
Absolutely, Ravi, you're 200% on the dot. There has to be a burning problem to solve, not a technology to implement. There has to be a burning problem. So that burning problem, if you say that, okay, it is there and this is what fits in, people will just definitely come with you.
The technology is only a tool to a mean. It's not a mean in itself.
I was telling that somebody comes with chest pain. I can't go to an AI and say, is he having heart attack or not heart attack? That's not a problem to solve. Okay. But oral cancer, different diagnostic, many things are there which are there. So you are very right. It has to be a burning problem which demands a solution.
Professor Vinod, another question. I'll just ask one question. We had the system of guinea pigs being taken for diagnosing diseases because the Charles Darwinian theory holds there. All forms of lives are connected in some way or other. So, but when it comes to demography of population, human population, why are we so saying that no, this is a European population, that data cannot be applied on Indian population? Can't the statistics of these geographically different places have some correlation? And why don't we work on those aspects?
To be frank with you, every medical system, at least in cancer, is been tested somewhere else also. So that much is there. We are not saying it not applicable, has to be tested. So the drug profiles, for example, for a Caucasian population may be too toxic for a malnourished Indian population. So they have to be tested and modified. They cannot be discarded. Data cannot be discarded. They can only be modified and tested. As far as guinea pigs are concerned, guinea pigs have stopped. After Maneka Gandhi came, all evolutionary process stopped once for all. After Darwin, Maneka Gandhi, that's all. After that, no evolution has happened. We don't use animals. We have a huge problem where there are no models available for testing anything, as a matter of fact. Drugs, pharmaceuticals, nothing can be tested because there are no models and no animal models.
Yeah, Vinod, maybe you should start curating burning problem list. I think this is what the technologists look.
20 startup ideas and maybe ₹1 million. Go for it. This is open source. You can just download and start a company tomorrow. Yeah.
Hello, am I audible? Yeah. So I wanted to bring the light of synthetic data sets in medical imaging. So US researchers are trying algorithms which can generate data, and those data sets from a generative perspective can use to train AI models at large scale. But there is always a hindrance. The generated data would not be as effective in the real world. What the panel think about the future of synthetic data sets in medical image and algorithmic analysis, large scale algorithmic analysis?
I mean, in general, you work with synthetic data sets, all generative models and everything are, so the theory is very simple. So a generative model, how does it behave? You give it some reference data, it will draw out boundaries. So this is my boundary within which all data should exist. And I will start generating all data points within this boundary. So essentially what we are seeing is that you are limited by the convexity of the data set which you have. So you are creating a bunch of samples which all satisfy that one single convex set theory behavior over here. Now, diseases, as we know, is departure from anything which is normal. So according to the definition, so what I have is the disease is anything which is really out of that convex set of what we can call as a normal human being. So if I try to generate any of those disease data, well, visually you can give a lot of storytelling around it. the bottom line over there is that you could have pretty much put down that generator inside your training routine, put it through an adversarial route, something over there, and even without generating the data and storing it separately, you could have trained out your model over there. So this is what it's going to come down. And for all data-driven learning models, it's the bottom line is always that they will always perform within the safe limits of the convex set of whatever your data point exists. Anything which goes way beyond what it has already seen, it will never be able to do it. And your generator, as such, by the same definition, your generator will never be able to generate a thing which looks very different from what it has actually been seeing or what is in your observation space.
Yeah, I'd just like to add to Devdut that, yes, those are going as far as generated methods are gone. If you're using more, science-based models, there are possibilities to push the limits and get into outlier spaces. And that is an active area of work. Folks are looking at that because, as I was mentioning earlier, data is going to be limited. No matter what you try to do, you can always find outliers for the existing models. So that is where the simulation-based data generation is something that is being explored. The challenge here mainly is how do you validate that? How do you justify that? And assess as you go forward. It's not very well established right now, but it is something that is in the field of research.
So like the panelists, I wanted to say that like excellent insights on this, but like there is a nascent field in machine learning, like in the field of artificial intelligence called like machine learning is evolving, right? Where you train a model and then you mitigate the biasness on that trained data. So like suppose I have a model, I have a synthetic data set, I train the model, I mitigate the distribution of that, and then I test the model on the real world. Do you think that machine learning or like, okay, there is one perspective of generative models going ahead because data is limited. Machine learning kind of a concept can move ahead. Like this question is specifically for the Dr. like Professor Debut here. Like, what do you think about machine learning in this domain?
We are actually making use of machine learning. I mean, if you don't look into the healthcare domain, then your Google is one of those very classical things of what machine learning does. Your translators today, if you turn on auto caption on your MS Teams, that is what is essentially doing all of those things. Broadly, it comes from the field of domain adaptation, excellently used. Healthcare actually uses in a very significant way. In fact, a lot of these imaging processes and whatever we do, they are all tried out in vitro. In a lot of cases, they are all with phantoms. And when you have the final thing going out over there, then you cannot get so much tons of data to do everything. I mean, you're just going to adapt that model. You learn some things which are very much plastic in nature on what it was done, and you make it much more organic. And then you have something which is great to be deployed at a much lesser risk of patient getting overexposed or anything during building of this model. So this is something which has been going on. It's not new for the community. The only thing which we need to understand possibly, and then why I was contradicting the whole synthetic data, I mean, Rakesh pointed out rightly, I mean, the possible way of going to that synthetic data would be to go through digital twins of human beings. That's rightly where you can tweak within your known understanding. So this is what so what I can do is I will have some definition about what a pathology will look from a textbook in medicine, and which is an accumulated history from the last 300, 400 years of medical practices, and then tweak that into my digital twin, and then look into what an imaging parameter, a physiology parameter, a genomic parameter, each of them is going to measure out if this happens. And that can have an excellent data set. Now, using those kind of data, if we are going to do that learning, definitely this is going to take care of machine biases. But we also need to keep something in mind that bias is not a universal phenomena. We are always biased with respect to the demography and the regularities we are in. So a certain disease which is not so prevalent in India, if you train it with a different data set, you might say, okay, it's unnecessarily biased, so it's over predicting that particular disease. But then if I change the data set, I make everything, I adapt the model and I say, okay, this is unbiased for India, does not necessarily mean that it is unbiased for China as well. You will have to take the model, you will again have to do the bias corrections for the Chinese population and then get it deployed over there. We just need to be aware of these points.
burning question.
Sir, I am Kirti from Kite Group of Institutions. So, as I don't know the much about this all over healthcare, but as I am a artificial intelligence and data science student, so data driven is, as data is very pretty much useful for all over the statistical analysis or testing data. Sir, I have one question. Like overall India, there are urban areas as well as rural areas. I think there are 50% of urban and 50% of rural, because every in India is still developing country, and India have still rural countries like villages and all. And villages have that much not system based. They are all paper based counting process. Like in COVID, in villages also they consulted RMP doctors or somewhat doctors. Then by how much data they will get, sir? How the testing data will be that much like accurate? Like all doctors cannot make it on system based, because some villages have some RMP doctors. Clinical can't able to access the system based files. So how the India overall India get the data, like how many people got affected corona, or how this data will be collected, sir?
You're asking a political question. How many COVID patients were there? India is a political question. It's a debate. So if you ask too strongly, then no, I don't know what's going to happen to you. But anyhow, the thing is that it doesn't depend on doctors to have get the information in the villages. You have the ASHA workers going from each village. There are public PHCs, then the district health centers. So the currently the NCDPS app runs on a smartphone or a tablet manned by an ASHA worker, which is fine, which is a good data. So it's not that doctors provide the poorest form of data. These ASHA workers give you very good data. So that is all there. And it's not necessary. The education level, etc., are not necessary at all as far as the data is concerned, because it's being collected by someone in the village itself. So that's not an issue. So we are seeing that there's a fairly good data coming up. That's not a problem. ASHA workers, then you have a PHC, they have what's called wellness centers now. 150,000 wellness centers are there. They are all there. So they can be used to collect the data.
Good afternoon, sir. Sir, suppose if we are going to develop an AI model based on medical diagnosis, so we will train and test some data based on that. But data changes every year, no, sir. Suppose for 2022, there will be some data who are affected with the diagnosis. How will you consider the same data for the next year as the population increases every year? Which data you are going to consider?
Build something with an online machine learning, which is what Googles of the world do as of today. Your web search, every I mean, I don't know what's the stat, but definitely there are millions of web pages and additional entries which keep on getting added every minute to the World Wide Web, and still Google is able to figure it out because there's a machine learning system which keeps on updating itself with this recurrence over there. Definitely with the healthcare data, you don't have to keep on updating yourself every minute, but then even if you're updating yourself every quarter or 6 months, that should be good enough to take you with these updations and the trends which diseases are forming over a period of time.
This is exactly what we talked about longitudinal data, saying at different instances in time, how is your body behaving, what medicines have you taken, and what the outcomes have been, and that will sort of form a basis for you to develop your set of algorithms.
Okay, so we have come to the end of this panel discussion, right? And I would like the panelists to make a final.
I have to ask a question. I have to ask a question, sir.
You want to ask a question? Okay, go on. Yeah.
Good afternoon, sir. I am Nagbabu from Kite Group of Institutions. So let's take a situation like if a AI system is adapted to one type of environment, because when a patients come and give percepts to that the system, if a patient get a new disease, but the system cannot recognize that the given person without clarification of that data, how that the system can predict that the outcome. So So when compared to that AI system, a real doctor is right, because a real doctor can understand the perceptions of patients with clarity. But a machine, how that machine can recognize that?
See, yeah, I think what you there is always an interface, the human interface. See, when you have this thing, a human interface is there. It's not as though that you're talking to a machine and machine says, "Oh, tomorrow you have something else." That's not the issue. There is a person who can be a healthcare worker who takes the symptoms and puts it into the system, and the system gives a possible answers. Finally, the assistant will say that, okay, you may have a problem or you may not have a problem. I'm going to take you to escalate to the next level. So it is never that the machine is the the final word of for the patient. So there is always, and there has to be a human interface. Medicine is not about diagnosing. Medicine is about how you tell the diagnosis to a patient. How do you guide him through the next process? So machine will never replace, and doctors need not worry. Nobody need to worry. It should only assist the doctors or doctors. Or let's even do not put doctors, healthcare professionals. It can be nurses also. Oh, pretty good actually.
So without human interface, that AI system will be harmful to us.
It won't be harmful to you. You will not. It will not function unless what is the unless there is a data coming in. What is going to come out? Nothing is going to come out. No.
When machine does not understand given percepts.
Yeah. Many times I'll tell you in confidence, doctors also don't understand what the patient is saying. But don't worry about it. Something will come out. Something will come out. No, one injection will come out, one colored pill will come out, and then a packet will come out. Don't worry about it. That will ensure.
Okay, sir. Okay, sir.
See, don't worry. The machines are never going to replace anybody. Don't worry. It may replace some automotive workers, but not medical healthcare professionals.
Okay, sir. Thank you.
Okay, I think we have come to an end, right? So I'd like to thank our panel members for taking time off from our busy schedule, right? And we truly appreciate and also keeping going forward, right? We are going to also see a lot of things changing in how healthcare is going to be progressing, right? And we hope that the AI technologies will have an impact at multiple levels, and we are all true beneficiaries of that, right? With that, I thank all the participants also for patiently waiting and listening to all our discussion points. Thank you so much. Thank you. Yeah.
Thank you, Vinod.
Thank you all. See you.
Great meeting
you.
all the
Thank you.
participants. Bye.
Just a moment. Oh, yes.